Hello, my name's Kevin Fernando. I'm a GP partner at North Berwick Health Centre near Edinburgh and also Education Director of GPnotebook Education. Welcome to the current season of GP Notebook Podcast, a bite-sized regular chat for all of us working in primary care. Podcast will cover clinical tips and hacks as well as hot topics to help make our lives a wee bit easier, but ultimately to help improve the lives of our patients in primary care. I've been recently involved in planning a series of webcasts for healthcare professionals in the UK, which are all taking place during May 2021 as part of what we're calling Chronic Conditions Month. The webcasts, which are being run in association with GP Notebook, are designed to help all of us working in primary care with the significant challenges we've faced in diagnosing and managing chronic conditions over the past year in the midst of the COVID pandemic. Healthcare professionals in UK can register to attend all the events for free at www.chronicconditions.co.uk. So I hope you'll be interested in joining us. And to accompany these webcasts, the Chronic Conditions faculty has recorded a series of podcasts in the past few weeks in which we provide some practical advice and suggestions to help you optimize care here and now across a range of conditions. So, without further delay, please enjoy the 6th of these special episodes now. This one features myself and Dr. Yassir Javaid.
Hello, I'm Yassir Javaid. I'm a GP with a specialist interest in cardiology based in Northampton, and it's a huge pleasure for me to be joined today by my good friend and colleague, Dr. Kevin Fernando, a GP with a specialist interest in diabetes at North Berwick Health Centre, which is near Edinburgh. So welcome to our new podcast, which comes to you as an introduction to Chronic Conditions Month 2021 to be held throughout May. This will include a whole string of interactive and informative webcasts designed to address the primary care challenges of diagnosing and managing chronic conditions at a time when COVID-19 has thrown out the rulebook. Today in this podcast, we're going to be discussing the importance of testing for chronic kidney disease, and in particular looking at the ACR and eGFR measurements and their relevance perhaps in terms of cardiovascular risk. Kevin, this is such an important issue for us in primary care, renal function, and in particular chronic kidney disease. Any specific guidelines that we can use in primary care to help us firstly to classify CKD and also to predict the risk of adverse outcomes?
Yeah, good question. Yeah, so we need guidance, don't we, in primary care, but to help optimize outcomes for our patients living with CKD. But you know what it's like in primary care, we're inundated with guidelines, aren't we? But actually, we have two fairly pragmatic guidelines, very relevant to people living with CKD. First one, slightly older, the NICE CKD guidance, published originally in 2014, but actually just closed to consultation for the updated version. So hopefully we should have an updated NICE CKD guideline perhaps later this year. So that very eloquently in a couple of charts summarizes the different stages of CKD, stages G1 to G5, and also the stages of ACR category as well, A1 to A3, depending on the amount of protein in the urine. And it produces a useful heat map to tell us the risk of that individual developing adverse consequences. Largely, as I'm sure we'll be talking about, cardiovascular disease, and also usefully suggests a number of times we may want to check eGFR and ACR for that individual person. So that's largely the guidelines I've been using for my patients living with CKD. But actually, hot off the press, just published towards the end of 2020, December 2020, we had updated KDIGO guidelines, specifically actually looking at the management of diabetes and coexisting CKD. And again, very much use this similar sort of heat map approach, traffic light approach, very pragmatic, very user-friendly. So I would suggest these are the two best guidelines for us to follow in primary care. Both are accessible online at the NICE website, the KDIGO website, with some useful downloads to help us classify people living with CKD.
So it sounds like very sort of helpful, practical guidelines that we can implement into our routine clinical practice.
Yeah, absolutely. Because it's very important, isn't it, that we identify those individuals with declining EGFR and escalating urinary ACR. Certainly, from your cardiovascular background, I'm sure you're very aware of the implications of declining EGFR and escalating ACR. But I thought it might be useful just to expand a wee bit on that discussion and really to highlight the importance of identifying these individuals early on.
No, absolutely. Firstly, let's be absolutely clear. CKD is a leading risk factor for adverse outcomes, and actually, quite recently, we've realised how much of an independent risk factor it is for cardiovascular disease. In fact, you mentioned diabetic kidney disease. We know diabetic kidney disease is the leading cause in the UK of end-stage renal disease and going on to dialysis, but sadly, many of these patients with diabetic kidney disease don't even make it to dialysis because of their very high cardiovascular risk, and they very often succumb to cardiovascular disease. And talking about those two components, I think it's important to understand that they're really giving us different information about the kidney. I mean, the EGFR is really a functional status of the kidney. You know, what is the filtration capacity of the kidney? Whereas the ACR is really telling us about the internal structural damage, giving us an insight of what's going on inside the glomerulus. How leaky has it become to proteins? And they are very different. And in fact, you can get a normal EGFR. Perhaps we'll discuss this a bit later on, but an elevated ACR. So it's really important we look at both, because they are additive in terms of how we should risk stratify patients with CKD, and certainly additive in terms of their risk of adverse outcomes, particularly cardiovascular outcomes.
Absolutely. I think that's such an important point, isn't it? That the effects are additive, but they're independent though as well, aren't they? They're independent predictors, like declining EGFR and rising urinary ACR. So that's why, it's a key, for example, checking urinary ACR was a key part of QOF, wasn't it, in the past? And that was a major concern of mine, as you're probably aware. Well, we lost QOF, of course, in Scotland about 3 or 4 years ago now. But the routine checking of urinary ACR, particularly for people living with diabetes, was removed from QOF, wasn't it, Yassir? So what's been the impact of that removal of that index from QOF, and what are the implications of this in the longer term?
Well, sadly, but not unsurprisingly, it has led to a significant reduction in ACR testing, certainly in England, looking at the data. I mean, clearly there's a lot of variation, but overall the rates are significantly reduced, which is a shame, really, because, for people living with diabetes in particular, I mean, often that's the first thing that gets elevated in the trajectory of diabetic kidney disease. Early on in diabetes, when it starts to damage the kidney, you get hyperfiltration, which actually increases the leakiness of the kidney to protein. And just missing out on that ACR at that stage will mean that we're not going to be proactive at identifying and therefore addressing that decline, that inevitable decline in renal function. And it is a shame, because there's so many more strategies that I'm sure we're going to talk about a bit later on that we can adopt to really try and reduce that decline. But clearly, if you're not identifying it at its earliest stage, that initial trigger is that raised ACR often. And I think we are missing out on that in many patients. And of course, this has been magnified in the current climate that we're living in, where many of our reviews are now being done virtually. I mean, what's your experience, Kevin, in Scotland? Something similar in recent
Absolutely.
times?
As I said, we lost QOF a number of years ago. So after that happened, inevitably there was a drop in urinary ACR checking. And then, as you said, sadly, with the pandemic, this has been worsened again. So I know it's something that we do need to maintain as a clinical priority for people living with diabetes, but also people, say, living with hypertension as well, because, of course, hypertension is a common cause of CKD as well, isn't it? So this is something we do definitely need to maintain as a clinical priority.
So, Kevin, You mentioned those fantastic guidelines that we have. What do they tell us about how often we should be checking EGFR and urinary ACR in someone with established chronic kidney disease?
Absolutely. I'd very much encourage our listeners today to download either the NICE or the KDIGO guidance, that heat map, those heat map algorithms, which gives us a clear steer, some suggestions on, of course, how to classify CKD, but perhaps how often we should be checking ACR and also EGFR. So, for example, a typical patient with, say, CKD stage G3A, so that's an EGFR between 45 and 59, and say stage A2 of ACR. So that is albuminuria between 3 and 30 milligrams per millimole. Actually, just one check a year would be adequate, okay? Of course, we need to individualize these recommendations. However, someone with more significant renal dysfunction, stage G4, so an EGFR between 15 and 30, and maybe stage A3 in terms of ACR, so that's over 30 milligrams per millimole. Recommendations from NICE, from KDIGO, would be suggesting checking that individual at least 3 times a year for both for EGFR and certainly to quantify any albuminuria as well. So, of course, these are just suggestions. They can be very much individualized to that person in front of us. And of course, there are some situations, of course, in most more functional dependence and frailty where we'd be taking our foot right off the pedal, wouldn't we, and be taking a more pragmatic approach in our more frail, more elderly individuals.
I think they're really helpful because probably in some instances they're going to hopefully guide us not to check the renal function too frequently. But in those patients where the risk is so much higher, particularly a risk of deterioration, perhaps just giving us that pointer that we should be keeping a closer eye on that trend. And you talked about frailty. Any sort of particular nuggets that you can give us about CKD in older and frailer patients? The evidence does suggest that the majority of older people with CKD do not progress to end-stage renal disease. So what does that tell us about how we should be managing their renal?
I think this is a very interesting issue and very much consistent with our realistic medicine agenda in Scotland, and relevant to wherever we work in the UK. There was a really good paper published in a BMJ around about 2016, I think, and it was entitled CKD in Elderly People. Is this a disease or a disease label? And really what it says is, as you outlined yourself, really around half of people over the age of 75 currently meet diagnostic criteria for CKD. But actually, the vast majority of these older people have CKD that does not progress to end-stage renal disease, requiring dialysis or renal transplantation. And actually, when you look at the data we've been briefly talking about associating cardiovascular risk with CKD, that data isn't actually age-specific and really is mostly relevant to people with more significant lower levels of EGFR, so certainly below an EGFR of 30, for example. So actually, very interestingly, the authors of that paper argue that CKD stage G3A is perhaps not significant in older people, and maybe we should lower the threshold to an EGFR of 45 from an EGFR of 60 to diagnose CKD stage G3A. So I thought it was very pragmatic, very holistic, and as you said yourself, to try and avoid over-treatment, over-medicalization of CKD, which is actually part of the aging process, isn't it, Yassir? So really what I always discuss with my colleagues, probably a more useful question to ask ourselves in terms of how aggressively, if you like, we want to manage that CKD. Is that person in front of us likely to require renal replacement therapy within their lifetime? And of course, if the answer is yes, it is someone we're going to be phoning a friend, isn't it? Referring to renal or maybe starting some of these newer therapies we'll be talking about just shortly. But clearly, if you sadly feel that person in front of you is unlikely to require either dialysis or transplantation or not fit enough to do that, of course, we can take our foot off the pedal and take a more pragmatic approach. So I thought it was a really interesting paper and very relevant with our aging population to try and not over-medicalize CKD.
Yeah, well, thanks, Kevin. I mean, clearly we're practicing in a much older and frailer population than we used to. So perhaps, I guess what you're trying to say there is maybe even accept sort of milder degrees of renal dysfunction as part of the normal aging process,
Absolutely. Yeah.
and not to over medicalize.
So I just wanted to talk a wee bit about EGFR itself. Yeah, so that's a common abnormal blood test we find, isn't it, in our DocMan inboxes. So I wanted to talk about perhaps some of the pitfalls and cautions when interpreting abnormal or even normal EGFR values, because as the name suggests, it's an estimated glomerular filtration rate, isn't it? So error is possible. Do you want to maybe expand a wee bit on that, Yassir?
Oh, absolutely. I think the key is that it is only an estimation. I mean, it's a pretty crude estimate of renal function. I think for me, the trend is probably more important than the absolute number. And that's where I see the great role of EGFR. It's really good at looking at the trend in renal function in an individual patient. But for absolute estimation of renal function, for instance, for certain drugs that are really reliant on renal pharmacokinetics, then certainly in cardiology we very much use the Cockcroft-Gault creatinine clearance, which is still an estimation, but it does factor in things like the weight, and certainly for me weight should be factored in, because I mean, if you've got an elderly frail patient with low muscle mass, your EGFR is going to be fairly inaccurate as an absolute measurement of renal function. You're going to be overestimating the renal function. So for drugs like the DOACs, for instance, it's now standard practice to use Cockcroft-Gault creatinine clearance calculations for the dosing. I'm not sure what your experience is on that in terms of dosing drugs used in diabetes, Kevin. I mean, in cardiology, we very much move towards that.
No, I completely agree with you. For our high-risk medications, we should be using creatinine clearance. EGFR is really EGFR was really to be used only for the diagnosis and staging of CKD. But yeah, ideally for dosing of all drugs, actually, we should be using creatinine clearance. But we've got to be pragmatic as well, don't we, in primary care? But absolutely, high-risk drugs, the DOACs, as you mentioned, things like lithium as well, certain high-risk antibiotics like gentamicin, etc. So I absolutely agree with you. And there can be, especially at those lower EGFRs, there can be quite a discrepancy, can't there? But as you said, between the GFR and also the creatinine clearance.
Yeah, for me, for me, it's that older sort of patient with lower muscle mass. I've seen EGFRs that are almost double the sort of Cockcroft-Gault creatinine clearance calculated. And Kevin, do you also agree with me that really it's the trend in renal function that's almost as, perhaps even more important than the actual static renal function that you've got in front of you?
Absolutely. And I think that's the same for several blood tests, isn't it? What is more helpful is the trend, the direction of travel to help guide your management. The analogy is the HbA1c. So actually in CKD, very appropriate. We're talking about that just now. HbA1c is not so accurate in CKD either because of underlying anemia associated with CKD, increased red cell turnover, other reasons like that. So actually what's more helpful in CKD is just looking at that trend of HbA1c. So I absolutely agree with you. Again, I think that's a very pragmatic approach. And, ultimately in primary care, we're pragmatists, aren't we? And I think that's one of our key strengths.
Kevin, on a very practical level, most GP software systems, certainly the ones we have in England, and have these Cockcroft-Gault creatinine clearance calculators embedded within them, or they're very easily available online as well. So it's really not a major undertaking to sort of go that extra mile and get that more accurate estimation for most patients. I mean, do you have similar integration with your software systems in Scotland?
Absolutely. We use Vision in North Berwick, and it's integrated into Vision. But I use a lot of smart apps as well on my phone. There's a number. I have no conflicts of interest here, but MedCalcs I find a very useful app. I'm sure you've used it as well, with not just for creatinine clearance. There's questionnaires such as the Epworth Sleepiness Score. Simply calculating BMI. A lot of helpful calculators. So yeah, they can be very helpful too.
I'll totally endorse MedCalc. It comes in handy on more than one occasion, usually in a busy morning. Kevin, we've talked about the pitfalls of interpreting the EGFR. What about the ACR? Isn't that a more straightforward thing to interpret, or are there any pitfalls or cautions that we need to consider?
Yeah, you would think it was hopefully more straightforward, but there's a couple of potential pitfalls anyway we need to be aware of. I suppose not really a pitfall, but the first thorny issue is this issue of do we need an early morning urine sample? That's traditionally what we've always asked for. And the reason for that is because one cause of transient protein in the urine is what we call orthostatic proteinuria. So once you've been upright for a few hours or longer, that can lead to a slight benign leakage of protein into the urine. So that's why traditionally we've always said get an early morning sample of urine, because we've been recumbent hopefully overnight. So there should be minimal impact of orthostatic proteinuria. But actually, speaking to our renal colleagues, the amount of leakage of protein due to this orthostatic effect is negligible. It's not clinically meaningful. And really the clear message from our renal colleagues is any urine is better than no urine. So don't worry about getting that early morning urine sample. Just get a sample at any time of the day. And actually, if it's handed in late in the day after the lab van has been, it can be stored overnight in a fridge in just a white topped container. And what we're looking for when we send that away is a value of over 3 milligrams per millimole. That is clinically important proteinuria. That said, aside from orthostatic proteinuria, there are some other causes of transient albuminuria too. So that's why, very importantly, we need 2 positive samples over 3 months. So what are the causes? Well, biological variability. You just get a natural, like with many tests. Recent heavy exercise can also cause some protein in the urine. Urinary tract infections, of course, but indeed any febrile illness apparently can lead to proteinuria or albuminuria. From your department, decompensated heart failure can lead to significant albuminuria, can't it, Yassir? Menstruation in women, acute fluid shifts as well, and any actually in terms of people living with diabetes, or actually even without diabetes, any acute changes in blood sugar levels or blood pressure can also cause albuminuria. So as you can see, like the EGFR, it's not a perfect test, and there are other clinical scenarios we should be aware of that may potentially be a cause of transient albuminuria, which once again is why it's important we take we only diagnose clinically important proteinuria if we have 2 positive samples over 3 months.
Yeah, I think that's such an important point. So I think in conclusion, ACR is a very sensitive test, but it's not directly specific or 100% specific for structural damage to the kidney. And you mentioned this 3 months apart. Do you recommend that we do repeat it at 3 months or any time within that 3 months? Are there any guidance on that?
Again, I think we can be fairly pragmatic. Also, given the pressures we're under with the pandemic and reduced patient contacts, I think the key thing as we started this conversation is we don't want to miss true albuminuria, because if it's, as we discussed, potential impact on adverse renal and cardiovascular outcomes. So I think it'd be reasonable to check it, even after a month, month to 6 weeks, if you have that window of opportunity. Absolutely. So yes, I'm conscious of time. It's been really interesting chatting about this. I thought perhaps a nice way to finish up our discussion today would be to talk about some of the exciting new therapies in the pipeline, or indeed not even in the pipeline, available to us now to potentially prevent that decline in EGFR, that progression of CKD, but also to reduce that proteinuria as well. So for decades, our renal colleagues, we in primary care are well versed at using ACE inhibitors or an ARBs, aren't we? If we see that clinically significant proteinuria over 3 milligrams per millimole, we would offer, wouldn't we, an ACE inhibitor or an ARB if not tolerated. But actually, the SGLT2 inhibitors now have a pivotal role to play in reducing progression of kidney disease. It's an exciting time, isn't it, Yassir?
No, absolutely. I mean, the renal specialists must be particularly excited because they have had, let's face it, very little in their arsenal to try and combat this issue. But even aside from therapies, I think, just making sure that we tell our patients to, enjoy healthy lifestyle, regular exercise, but also, very importantly, from an early stage, think about trying to switch therapies that could be actually damaging the kidney, and in particular, things like anti-inflammatory medication that can be strongly associated with worsening renal dysfunction. But yeah, totally agree with you. I mean, the ACE inhibitors for me have been the standard of care for renal protection for so long. They reduce that glomerular pressure. So you do get a slight reduction in EGFR, but that's really not a bad thing because that, reduction in glomerular pressure really does help with that renal protection. And then more recently, we've got really good evidence. I mean, some of the evidence is quite spectacular, actually, in terms of how the SGLT2 inhibitors also, by a different mechanism, reduce that glomerular pressure. Again, just accept a slight reduction in EGFR. In fact, you don't even need to check the renal function after you've started an SGLT2 inhibitor, but they're showing incremental benefit on top of ACE inhibitors in terms of renal protection in patients with diabetes. And more recently, we're now getting evidence even in patients without diabetes. So for me, very exciting, and we're hoping that one or more of these will be licensed for that specific use, even in patients without diabetes in the future. So very exciting, and I guess we've just got to watch that space.
Absolutely. That updated KDIGO guideline I mentioned to you earlier on in terms of classifying it, it also places SGLT2 inhibitors as a new pillar of the management of CKD. So well worth, as I said, having a look at that guideline, bang up to date, just published December 2020, and includes the pivotal role of SGLT2 inhibitors. But as you said, very much alongside important lifestyle measures too.
I also just want to end by making I think, really important point that we've almost got to change our mindset with CKD. In the past, we're very reactive. You have to wait for the kidney function to be really bad, EGFR lowered, perhaps not even looking at the ACR. Let's try and be really proactive. Let's not just look at the EGFR. Let's look at the ACR on a regular basis, especially in a patient with risk factors, diabetes, hypertension, coexisting cardiovascular disease. And the moment we see any sign of early deterioration, we should be now deploying a broad and fairly aggressive strategy early on to try and alter that trajectory. And there's so much more we can do now, isn't there, Kevin, than ever before?
Absolutely. We've got a number of tools in our toolbox. The analogy, again, with your background is heart failure, isn't it? A number of new tools in our toolbox to pharmacologically tackle heart failure. Similar situation with CKD. So I think a key role for us is to raise awareness of these new tools and to ensure we prescribe them in an effective way, but as you alluded to as well, in a safe manner as well, to ensure that risk-benefit ratio remains positive.
Fantastic, Kevin. I really enjoyed that discussion. Thank you all for listening. We hope you found this podcast helpful. Please make sure to register both for the other podcasts in the series and for our interactive webcasts brought to you as part of Chronic Conditions Month 2021. You can sign up at chronicconditions.co.uk.